Hello, everyone. This is Julie. Thanks for joining us today for today's webinar. I put the notes for today's PowerPoint in your handouts section of your control panel, so you can download that. There are a couple new things, of course, that we added. If you have any questions or cases you want to share, we've got 2 of them already pre-submitted. If you have another one, send it to me through your question panel. I'll cut and paste and get that in today as well. So it's going to be fun this way. He's got some of the latest and greatest things he just is dying to share with you, and then we'll get into your questions. So thanks for joining us on today's webinar with Dr. Cox. And I'm going to turn it over to him now, lover of all things spine and cases and patients with back pain. So your turn.
Thanks, Julie. This is certainly a different venue. We're opening this up to take on clinical questions today. I've never done such a thing. I don't know that you ever have. We're soon going to find out how it works. I would like to begin with 2 guidelines to share with you why we're doing this, and in my opinion, what the direction of our profession best follows. Well, if we look here at Joint Bone Spine, published last month by the European guidelines, and here they are. I've taken these guidelines and broken them down for you. I'd like you to notice something about them. These are 44 references, including chiropractor authors in this. However, no mention of chiropractic is made in the European guidelines, although we're referenced in them. Low back pain is no longer considered an isolated disease, but rather a whole disease. It is a whole person. Today, we are no longer discussing non-specific low back pain. It's being termed common low back pain. Drugs have been downgraded to second-line treatment after non-drug treatment. We are first-line treatment, therefore. However, you'll note that in these studies that many comments are made that I'll just abbreviate for you that to me were quite important. Physiotherapy for patients with chronic low back pain who are at risk for becoming chronic. That in this, the physiotherapist participates in a patient's education. They discuss this. There's no mention of chiropractic. There is manual therapy, however. They go on about manual techniques, meaning SMM, spinal mobilization and manipulation, only as a part of a multiple combination of treatments with exercise. They go on to talk about second-line treatment of opioids. They discuss Tylenol may be useful in a symptomatic intention. Non-steroidals may be offered after evaluation of is the benefit outweigh the risk. Antidepressants are not indicated for acute low back pain. They say ultrasound use and lumbar traction are not recommended. Orthopedic insoles, acupuncture, acupressure, not effective. I didn't write these. I'm just sharing with you what international guidelines are saying about common low back pain. Lumbar supports may be considered a short time. We can't determine the benefit of corticosteroids. Muscle relaxants have an unfavorable benefit risk balance. No indication for antibiotics. Then here in Spineline, which you may have read, in North American Spine Society, they wrote in April of 2021 their primary guidelines. When you read them, pretty much the same thing. They're like back school, including physical therapy, can improve back pain. There is insufficient evidence that McKenzie exercises for acute low back pain are any better than usual medical care. In patient ultrasound is not recommended. Conflicting evidence that TENS units are good. Laser acupuncture provides no short-term or medium-term agreement. I'm not asking you to agree with me, I'm just showing you what the international world is saying about the treatment. They're saying that for patients with chronic low back pain, now called what? Common low back pain, no longer non-specific low back pain. There's conflicting evidence that outcomes for spinal manipulation are clinically different than no treatment, medication, or modalities. Geez. So you go on with all of this. Intra-articular joints injections may be considered for SI joint. Intradiscal steroids suggested to provide short-term improvements. But then look at this. All surgical procedures for low back and leg pain were reported as a systemic review of the literature yielded no studies to adequately address this question. So if you look at these, doctor, there really isn't anything that is absolutely approved. Anything from conservative through surgical care. I wanted to share those things with you. There's insufficient evidence to rule for or against the cost utility of physical therapy, spine manipulation, mindfulness-based treatment, surgery versus medical care. So when you look at all of these, there was one paper that the North American Spine Society cited as positive. I'd like you to note what it was. It used our technique. It was published by Murphy and Hurwitz. Don Murphy from Brown University, Hurwitz from UCLA, both chiropractors. They performed this prospective study of 57 people with confirmed lumbar spine stenosis. What did they find? In these 41 patients, clinically significant improvement of greater than 3 points in the Rollin-Morris was found in 2/3 of the patients, self-reported improvement in 76% of the people. They cited Cox Technic in treating these people. To me, and you read it yourself, this was the only positive thing I seen published about that. And yet here's another paper out of Spine Journal, March this year, about treating degenerative spondylolisthesis. They say that the North American Spine determined the appropriate treatment of multidisciplinary treatment in treating degenerative spondylolisthesis. They recommended PT, epidural steroids, surgery, no chiropractic care. My point here, doctor, is that when you look at this paper, 4 out of 10 guidelines in the management of lumbar spine stenosis were of adequate methodological quality to endorse surgery and injections, but not non-surgical care. I find this to be troubling to me because my profession, and I can tell you personally, all the work that we do as individual practitioners and as a profession deserves to be more complementary in the literature today. What do you think about this? Here's a paper came out May last month on complementary clinical practice about the use of osteopathic manipulative treatment in the newborn nursery and its effect on health in the first 6 months of life. Well, they found that it is very positive. Given to a newborn, positively affects a baby's short-term and quite possibly long-term health, specifically relating to GI complaints and irritability. In another paper, how about this paper? Did you see this one out of Healthcare Basel, April this year? This paper is talking about T9, T10 vertebral manipulation for tonsillitis. Now, when you first see that, you say, oh my goodness, what is it? Well, if one doesn't think about inflammatory, what we call inflammaging and inflammatory disease, one could not appreciate this paper. But here, they're talking about the benefit of treating tonsillitis by T9, T10 manipulation. Another paper, chondroitin sulfate. And those of you know, if you don't use it, you better start studying it, in my opinion. Chondroitin sulfate in the treatment of osteoporosis, we know it's anti-inflammatory. to attempt regenerative changes within the intervertebral white fibrocartilage of the disc. That chondroitin sulfate modulates the gut microbiome by chondroitin sulfate and alleviates osteoporosis in overectomized rats. So to think about these things and preface our study, we are going to look now at certain cases. And I'm going to skip these papers. You can read these on your own. I will mention this one to you. Came out this month in Journal of Musculoskeletal Neuronal Interaction. Can vagus nerve stimulation influence bone remodeling? Kurt Olding just sent me a paper today about the vagus nerve, the research done at institutions like Northwestern, University of Pittsburgh, Harvard, on the function of the vagus nerve as an anti-inflammatory influence by powering up the parasympathetic or the sympathetic nervous system. So can the vagus nerve influence bone remodeling? Yes, it can. The implantation of a vagus nerve stimulator is associated with an increase in lumbar bone mineral density. This can lead to a new treatment of osteoporosis. Do you think about that when you think about what our profession does? So in order to open the discussion and gain interest with you and with me, I have placed this challenge to accept your questions and do my best, although I realize inadequately, to address your questions. Would you do this? Well, let's look at some of these. Here's a paper, one paper sent in, right?
Yeah, this question that was sent in.
A question.
I told them to send it in early.
Okay. This question, my question is based on a complicated case of a patient who has tried many forms of non-drug and non-surgical care for what I would call an unstable lumbosacral condition. The patient's 50-year-old tennis player, athlete, MRI, X-ray findings showed degenerative T12L1, L5S1 disc changes, mild corresponding modic type 2, very mild possible grade 1 spondylo at L4. He is rarely in pain, rarely has coldness in his right big toe. What nerve would that be? I believe that's L5, isn't it? But is frustrated because sometimes when he exercises, his low back feels like something has come loose. That shouldn't. And he'll have to stop all activity for a month or two. He is becoming very sedentary out of fear at this point. Question is, how can our technique play a role in stabilizing the lumbar pelvic area? Well, this patient obviously is describing to me degenerative spondylolisthesis at the L4 level. That would explain some of the dysesthesia of the right big toe, the back pain, the feeling of instability. If you remember, in didactics, we said we brace 3 conditions: intervertebral disc herniation, degenerative spondylolisthesis, and Bertolotti syndrome. When we brace these, it stops instability, it reduces instability, it aids the healing. So we brace these people.
Oh, I'll get it.
Okay. And I would like you to note, as the work of Aura Freiberg pointed out, and your case here would be an excellent one, doctor, to fit into this. In the textbook, and I would suggest you get the book. I don't make any money. All the royalties from Lippincott, Williams, and Wilkins go to Kaiser University College of Chiropractic Medicine for further research. So buy the book. You're enhancing your profession. But when you look in the chapter on spondylolisthesis, you will see the work of R. Freiberg. She tells you that you determine the stability of spondylolisthesis, true or degenerative, by how much movement you get on vertical suspension. You'll note here that we have the patient hanging from in front of the bucky by a suspended from the ceiling handle. As they allow their body weight to traction their spine, L5 or L4 will move in direct proportion to the degree of instability. As Freiberg's pointed out, if there is no movement, it's a stable spondylolisthesis. I have seen and show in this textbook cases of spondylolisthesis up to 50% that totally reduce and become retrolisthesis. That's instability. In those cases, therefore, in this case here, regardless of whether you see it, I would brace this case. The more instability, the greater the need for bracing, along with, and I would treat these cases sideline, and I would brace them with memory foam braces. No matter how you squeeze this thing, it always comes back to its original form. And as the patient wears this brace, their body heat will warm it, it will pack into the spine and give them support. 2 points about this. As you remember the work of Nachemson et al. In Spine Volume 1, Number 1, page 59, they pointed out that in turning from prone to sideline, the intradiscal pressures tripled from 25 to 75 millimeters of mercury. My point, I have people wear this to bed at night until 50% relief of the back and radicular component. It adds what? Stability. Golfers love to golf. I have them wear this to prevent that damaging rotation movement of the abnormal movement of rotation in golf. It reminds them, it prevents them from rotating. It reminds them to spare their low back. I received a paper today also. Incidentally, I had 1,502 papers today. How many of you read 1,502 papers today? I guarantee probably not many of you. I read them, I digest them. Every month I give you the pearls that say what those papers were. In my opinion, that makes us the best back specialists. But in this paper today, we're talking about rowers, how they lie to their coaches. What an abnormal thing to sit in a boat with your legs straight out and stress your low back repeatedly. They talk about the incidence of back pain, the changes in life, how they suffer a lifetime of back pain. I, for example, never have patients exercise on a rowing machine. Why would I want to aggravate the problem that I'm treating them for? In my opinion. So remember, if you have spondylolisthesis like this, or here's another one, another doctor sent this case in this morning.
Yeah, he put it on the, if you're certified, you can be part of the Facebook group, doctors who want to discuss Cox Technic. I'll send a link to you all for that. So this is a doctor. I didn't get to ask him his permission, so I'm just showing his comment in the picture because it fits.
Right. So here you have a true spondylolisthesis, 50% L5 on S1. Degenerative disc disease, small disc herniation here. He says, I've seen her 2 times. She's feeling much better. Protocol 1 while using a pillow, and I gave her some stretches and core stability exercise. I love how much confidence I have when I see images like this. And he's kind enough to say that the work helps. Doctor, for me, and you might consider, treat these sideline on the instrument. This doctor treated him by placing a small flexion pillow under L5. The contact is going to be at L4, and you're going to distract. Almost all of these people have short hamstring muscles, so you do doming of the diaphragm as opposed to PNF to stretch hamstrings. they do knee chest exercise, at least consider this way of treating them in addition to whatever you're doing now, and see if you can reduce these things in 2 visits. If you can or quicker, don't even consider this work. But if you can't, this is a beautiful case to do R. Freiberg's vertical suspension. As you hang from this bar and that weight applies, I have cases where this L5 not only totally receded, it became a retrolisthesis. Read R. Freiberg's paper cited in the textbook. That tells you and
Keep going. I got another question.
you and I about the incidence of instability. And if they're unstable, the better you stretch the hamstrings, you do knee chest, and you brace them. This is the pseudodisc herniation of spondylolisthesis right here. With stress put here, you already see begin a disc bulge and a little bit of arachidonic acid conversion into leukotriene and cytokines at the disc above. Brace these things, try it. Talk to Julie about that brace where you get it. It's made by DC Labs. The question?
I just sent a link on the DC Labs to your chat box too. I have a question related to spondylo. Dr. James asked, please comment on grade 1 spondylo at multi-levels. It's multidisciplinary management with chiropractic and injection.
Absolutely. Terry Oakham once gave me a case. He has a case of spondylolisthesis at all 5 lumbar levels. The most I've ever seen was 4 level. When you have, and doctor, at least consider doing this, do them sideline. Start with L5S1, 4-5, 3-4, 2-3, 1-2. Distract. And as you tolerance test and there is no iatrogenesis, then begin to apply long y-axis distraction with the flexion of the instrument in a sideline position. Brace that patient and brace them 24 hours a day till 50% relief of the back and or radicular component. Then stop wearing the brace at night at another 50% relief. Only wear it under strenuous situations like rowing or golf and the most dangerous movement of all, bowling. And the other part was apparently this doctor is using
Injections.
I assume by injections, I don't know whether you mean trigger point injections, epidural steroid injections. I frankly have never used epidural steroid injections with multi-level spondylolisthesis or single level. But if you do, I've seen people that have had them done, and we've been treating them within days after the epidural steroid. I feel that I don't understand fully the question.
That's all I've got. If she's got more info, send it back in.
Yeah, this is what this is about. Yeah. Looking at clinical cases. If anything else, my colleague, hang a bar in front of your bucky and vertically suspend them. What a thrill! What a thrill in clinical practice to see that spondylo reduce. And the greater, as Orr Freiberg said, it is not the degree of slippage that causes the problem. It's the degree of translational instability. The greater the movement on vertical suspension, the greater the symptomatology. If it doesn't move, look somewhere else for the problem. And in this case, already we see this disc degenerating because the movement here, what percent of flexion extension occurred here? Normally 75%, 20% here, 5% up here. When this degenerates, this disc is now doing over 90% of the flexion extension. It was never asked to do that biomechanically. So you and I must make up that insufficiency by giving stability. And incidentally, 2 things you do when they're symptomatic, like the case that just that 2,000 milligrams of Discat, that's chondroitin sulfate, with Boswellia serrata, devil's claw, and white willow bark, and quercetin, 2,000 morning, 2,000 afternoon for 3 months. Then cut that down by 50%. Put them on turmeric curcumin, 800 milligrams, 4 a day when acute to lower the chemical inflammation, with black pepper, turmeric, and curcumin in disc and joint pain relief. I even use this for anything in which there's cytokine inflammation, shoulders, knees, hips.
Okay, I got stuff coming in now.
Good.
All right. Dr. James says for co-managing patients in her practice that they're using epidural and foraminal injections in response to what you were talking about with the spondylosis. So I think we kind of covered that. Okay, I've got a question here. You ready? Can Dr. Cox comment on lumbar flexion and extension views done sideline if the imaging center does not have the equipment for hanging traction views? Dr. Baruti.
Thank you. As Ora Freiberg shows in her beautiful paper cited in the textbook, you can do flexion and extension studies and they not show greater than 3 millimeters of translational instability. That same patient, when vertically suspended, will show tremendous instability, as I mentioned, and she shows it, sometimes total reduction of the spondylolisthetic slip. The point being, flexion extension, while helpful, are not nearly as fruitful as what? Vertical suspension, because sometimes you will not see translational instability, which is defined as what by the work of Hayden et al. 3 millimeters or more movement of the spondylolisthetic segment, in this case L5, on sacrum. I think I answered that.
I think I've had 2 doctors tell me that they've gone to the imaging center and donate a bar and hang it there.
There you go.
If that's important, then they find ways to do it. So that's one idea.
When you do that, if you do your own film, and not too many of you do anymore, we don't even in our clinic. But I mean, donate a bar, have them vertical. Those radiologists will be very excited over this. You know what they'll do? They'll publish a paper and say, look what we found.
All right, next question. Dr. Tao is asking, hello and thank you for having this.
Is that Cliff Tao?
Yes.
Hi, Cliff.
What is your experience with retrolisthesis at L5S1? Are they clinically relevant? Are they pseudo, retro, congenital, or question mark? Thank you.
When we deal with people, Cliff, with people with degenerative disc bulging, sometimes I say that the degree of retrolisthesis varies directly to the degree of disc degeneration. However, in the literature, when I read the literature, I see people who are asymptomatic and have retrolisthesis of, say, L5 on S1, which is a very common level, and they're asymptomatic. And yet when people are symptomatic and they show reverse spondylolisthesis, or what we call retrolisthesis, I see that when degeneration of the disc takes place. An assumption could be that that retrolisthesis depends upon measurements such as the pelvic inclination. The less pelvic inclination, the greater the opportunity of retrolisthesis. Whereas the greater pelvic inclination, the greater the incidence of spondylolisthesis. In both conditions, some degree of intervertebral disc instability must be present. And to summarize your question, I would say that because you see retrolisthesis at L5S1, do not assume even that patient has back pain. It must be correlated carefully with the clinical, neurologic, orthopedic findings.
Okay. Next question kind of goes with this. How do you deal with a patient who loses confidence in getting better after they have an extreme flare-up of pain 3 to 4 weeks into treatment?
Oh, thank you for that wonderful question. Derek, thank you. Doctor, in my opinion, as a clinician and a radiologist for 55 years, 2 things I've learned. Number one is that treating men between the ages of 20 to 30 is a very difficult thing. You tell them they have spondylolisthesis and they're going to have it all their life, and there's a possibility that it'll cause them pain. They don't like that. They reject you until they get older and they come back and say, you know, doctor, there was some wisdom in what you said. The second thing about dealing with patients is clinical expectation. And that brings up the question, and Derek, you've been here and studied with me and Kurt and George and some of the finest, Dr. Hazen, who you're with now, tremendous practitioners that I've had the honor and the privilege of mentoring for whatever good that was. But when you study this thing, minimal clinical improvement, at the very beginning, it doesn't matter whether a patient's undergoing spine surgery, conservative care with drugs, or manual therapy with chiropractic. The important thing is to have an understanding with that patient at the outset of care of what can be a reasonable clinical expectation. If you and I are dealing with a 50, 60-year-old person, male or female, with spinal stenosis, I say this to them. You know that in medicine today, 30% improvement of your symptoms is considered meaningful improvement, meaning that the treatment we give you is worth undertaking. 50% relief in many of these cases is excellent. 100% relief is unrealistic expectation. Even dealing with this case, and this is not a really old patient here, I would guess this patient somewhere 35 to 40 years old. But this patient, I would tell them that if we can give you 50% relief and we can maintain that by ergonomic training, back school, teaching you how to be healthy living, what to do, what not to do, taking Discat, enhance the quality of your white fibrocartilage, and give you 50% relief, that may be the best clinical outcome. And once the patient understands that, I think we avoid your question. What about the patient you've treated how long? 2, 3 months?
Yeah, well, 3 to 4 weeks.
3 to 4 weeks, and they're still having pain. Well, for one thing, I tell them that a disc heals like a broken bone. 3 months. You got to give at least 3 months of dedicated care while I, as the physician, or you, the physician, carefully monitor neurology and orthopedics to see if there's any deterioration requiring interdisciplinary care. I have no problem at all with interdisciplinary care. We just heard a doctor talking about, and I assume, was that a lady?
Yeah.
She's in with an interdisciplinary clinic with surgeons and orthopedists, and that's fine, because that's where we can really show what we can do, and it takes on greater meaning. But at the outset, to answer your question, Derek, to me, you have to explain what is a realistic outcome. We're not the only ones guilty of not doing that. Surgeons do too. What is one of the biggest reasons that people are unhappy with their surgeon? Because they go in expecting 100% relief. It's not going to happen. You're not going to do everything that you did before with a back surgery and a fusion, with or without fusion. Same thing is true what you and I do. At the outset, tell the patient what is a realistic expectation. I even ask them, what would make the quality of your life improve to your point where you would be happy with care? I've had people say things to me, if I could walk to the mailbox and back, I would be happy. If I could mow the grass I would be happy. If they say, I want to do everything I did when I was 20, probably there's a lack of realistic expectation.
And I think the best thing is being a back pain patient myself is that healing is like kind of like a roller coaster. It waxes and wanes. And when it goes away longer than it comes, you're in the way of healing. I hang on to that with every episode that I go through.
Yes.
So there.
Yes, when I treated, Julia said,
and I've got a couple discs myself, so it's
she got a couple discs, and we've treated her, and I guarantee you, a surgeon would have operated on her right away. When you have foot drop, heel drop, and an absent Achilles reflex and a pure S1 dermatome sciatica, I guarantee you, some surgeons would operate. Always, unless it's progressive, conservative care. What percent of people go to surgery? In a study of 3 million people published in the Journal of the American Medical Association and the paper by Adagwa et al., in 3 million people, no more than 1.5% go to surgery. That means you and I, we owe it to those people because we're treating 98% or more of them to be the best informed doctor in a conservative care. And if we do that, our profession has boundless possibilities.
Well, since you're on that topic, let me go to this question, then you can do Dr. Poulin's. I've got one. Dr. Cox, student from Life University. Is there a particular reason as to why chiropractic care is not held to a high standard regardless of the numerous amounts of research we have? Curious on what Dr. Cox's approach.
Thank you very much for that erudite question. Number one, there is not serious research in chiropractic. We are attempting to do that at Kaiser University. We presently are starting a new stenosis study. Doctor, as a student, you're at Life?
Life.
Which Life?
Georgia.
All right.
Roll on.
You certainly are familiar with Steve Garber, are you not? I hope that you sit in his class in the front row and absorb everything that good man teaches you. All but one chiropractic college teach my work today.
Says he's an amazing guy.
Dr. Garber, sit there, ask him this question. Guarantee you he will answer it for you. I've studied with him many times. In fact, at the recent Fort Wayne seminar, I had Dr. Patterson from Cleveland College in Kansas City and Dr. Garber both in my audience. They teach students this technique. Their classes are absolutely filled with a waiting list. But to address this, we need more research. We're doing a study in spinal stenosis. Spinal stenosis in America is an epidemic. It is painful, it is costly in human suffering in dollars. There is no way that you will escape unless you say, I'm not going to treat people with stenosis, which pretty much takes everybody out of the realm. You must know that there are specific techniques that work best statistically for spine stenosis. We're starting a study right now. It's through IRB at Kaiser. We're going to have as many 20, 30 chiropractors treating for 6 months all of the spinal stenosis cases based upon the Swiss questionnaire and the LSS questionnaire, as well as imaging. And we're going to determine the days, the visit, and the degree of relief that they get from Cox flexion distraction manipulation. Now, this is what documents and gains attention in medicine today. Why, in my opinion, why is chiropractic more not accepted? Because we're our worst enemy. The ridiculous things I hear from chiropractors, free chicken on Thursday. I can treat anything and get you well. In other words, doctor, young student, listen to Garber. Learn what evidence-based clinical practice is. What is it? It is 3 things. It is number 1, research. Number 2, it is clinical expertise. It is your ability to use the most valid clinical improvement-based techniques in this profession today. And when you do research, clinical expertise, you reach the third level, which is what? Patient satisfaction. And that's nirvana. To me, that's what builds our profession. It's when the public say, I want this technique. Tomorrow, I will have the honor to examine doctor's son from another state. I do a lot of that. For some reason, when they really get into trouble, sometimes I'm asked to see them. I'm not sure why that is. I think it's because of what we're talking about. And when we talk to these people, they come to us because they have confidence. The one thing I would ask you, young doctor, study, become the best spine doctor you know how to be. Come study with us. I'd love to sit with you.
I think he has.
You know.
Recognize the name.
And when you get into practice, you influence all the doctors around you and show the public what our profession can do. I hope I answered that.
Right. And when we call you, when you are a doctor in clinical practice and say, we need your help collecting patients and data, you'll be there for us.
Yeah, join us in research. We only use certified doctors for research. In other words, I want our best put forward. How long have I been?
It is 1:10, and you didn't think you'd have anything to say today. Okay, do Dr. Poulin's.
I think this is exciting to have you ask questions.
And I still got more over here.
And if I don't give the right answer, you do tell me. You tell me what you would answer.
Right back to me and tell me you want to talk.
I guarantee you've never been on. I've never done a webinar like this. I've never heard anyone who did. Okay, Dr. Poulin, a certified Cox practitioner, excellent physician in Virginia, writes this question. I have a 63-year-old female who has L5-S1 degenerative disc disease, bulge, with sciatica and neuropathy, has been taking B12, 5,000 micrograms sublingually of methylcobalamin daily for several months. Now she's greatly improved. She has a fatty liver, stage 3, now stage 2 liver disease. Her B12 levels are over 2,000 on blood work. Her GP told her to stop immediately. We discussed the B12 that it usually passes out through the urine. Can you explain why her levels are so high? She got scared, stopped B12, will only continue her multivitamin. Dr. Poulin. Yes, great question, great clinical question. The normal blood levels of B12 are 150 to 660 picomoles per liter. Now, if those of you don't like picomoles, you can convert that into nanograms per liter like you do in PSA tests. But just know that if this patient's up to 2,000, that's far above the upper limit of 660 polymoles. And whenever you see that, and you already mentioned she has stage 2 liver disease, yes, this is a potentially very serious condition, and it's going to demand interdisciplinary care because of decreased liver function is a reason for the abnormal blood finding. Too much B12, side effects, headaches, dizziness, joint pain, swelling, anxiety, nervousness, lack of coordination, itch, numbness. She needs further blood workup. So this is a serious condition. And because she has stage 2 liver disease, we have to consider diseases like cirrhosis. You're going to look at leukemia, polycythemia vera. You're going to look at hepatitis, hepatocellular carcinoma. I don't know how many of you did Medscape this week. I do it with them all the time. There was a case of a young man with hepatocellular carcinoma of the liver. And so in this case, They need to have a strong metabolic testing done on this patient, all the liver enzymes, blood counts, interdisciplinary care. Certainly cut down I would maintain that she keep taking B vitamins, but stop the sublingual B12 until you can get an adequate explanation of this patient's liver disease, because that, to me, at this stage, is the foundation of the elevation in the methylcobalamin in the serum. Anyone want to comment on that? Or it's a good example of interdisciplinary care. You'll maintain a dialogue with her family doctor. If he is not an internist, this patient probably deserves that approach as well.
Okay. You ready?
Yeah.
All right, thank you. I've got now one case, Dr. Baruti. I have a patient diagnosed with Marfan syndrome. Flexion and extension view ruled out atlantoaxial instability. However, there was 1 to 2 millimeters of anterior subluxation of C23, 34, 4, 5, 5, 6 on the flexion view. And there was 1 to 2 millimeters of posterior subluxation at C4, 5, and 5, 6 on the extension view. With the Cox table, would you treat this patient's cervical spine?
Yes. Very gentle distraction, physiological range of motion. But with the Marfan syndrome, the hyperflexibility, I don't know whether your patient has any heart disease, but that's certainly something you're going to look into very carefully. You're going to use, based upon exam, strong stabilization exercise, motor and stability exercises both. This patient will have hyperflexibility throughout their body. They will use the headband.
No.
They have a headband.
Yeah.
And because of the multi-levels of instability, I would be very, very gently in manipulation, only to the point of making sure that we have full physiological range of motion, and then stabilize. And what is the greater, the cervical or the upper thoracic, in stabilization and normal physiological range of motion of the neck, treating the upper thoracic spine? So you are going to treat upper thoracic syndrome, physiological range of motion of the upper thoracic spine, which incidentally are what cardiac nerves and respiratory sympathetics. And you're going to work more at the upper thoracic than in the cervical with spinal manipulation.
I don't have it.
And you're going to use a cervical headpiece. Maybe you can send him a picture of it.
I'll send you that.
And they're going to begin strengthening, and you'll find extreme weakness in this patient, I think, in all ranges of motion of the cervical spine. But as you use PNF, as you use the headband exercise in all 8 directions, flexion, extension, lateral bending, rotation, and this patient begins to have a strengthening of muscles, you'll find that the stability of that neck greatly improves. With Marfan syndrome, it certainly is not going to be total, but you're going to have to treat very strong with exercises, mainly manipulation of the upper thoracic spine. And I would assume probably they have some hyperkyphosis of the upper thoracic spine. And this will be a case because of the slippages in the neck that you'll use long y-axis distraction with extension movement of the upper thoracic spine.
Another question, how do you use the celiac plexus massage technique to avoid compressing the abdominal aorta?
Stay in the midline, stay where the celiac plexus is, don't get off to the left side. Have you ever noticed something that when you palpate abdomens, some people, the abdominal aorta really you can feel it. Some people you can feel very little. So when you feel it, move your fingers to the right side and come in an oblique posture onto the celiac plexus.
All right. Let me see what other ones.
Celiac plexus, midway between the xiphoid and the umbilicus.
Okay. I have good results in managing lumbar stenosis with Cox in older patients, but it is generally short-term relief, 1 week or so. What am I missing?
I'm not sure. I would assume that if you're getting relief within a week.
She said, but it's generally short-term relief, 1 week or so. So the relief only lasts a week. She's doing managing lumbar stenosis with Cox in older patients well, but it's generally short-term relief, 1 week or so.
Doctor, you're going to have to start treating longer. There's no way that in a week or two that I can, through motor and stability exercises, gain the strength and stability of the low back, the thigh muscles. I treat these people with the rule of 50%. In other words, if your patient has no radicular component, I treat them 3 times a week till 40 to 50% relief. In the meantime, they are doing their exercises. I like back school. I give them back school. I invite them to back school. But they are doing at least the exercises. Abdominal tightening, abdominal oblique strengthening, extension exercises, because in your patient, if you test their gluteus maximus and multifidus rotatories muscles, you will find they're very weak. 60% of people, doctor, with spinal stenosis have Katz-Nelson's gluteoskyline sign. That is, they have gluteal medius and maximus atrophy. Why? Because the nerve supply to these muscles is L5S1 nerves, which when you and I treat is involved in over 90% of the cases. Therefore, they must do exercise number 6, which begins with eversion of the lower extremity and extension of the buttock of the lower extremity to strengthen the gluteus maximus muscle. They will also do extension exercises in the 50% improvement or the absence of radicular component in order to strengthen the multifidus muscle, because the weakest muscle in the lumbar spine, if you look at iliocostalis, the multifidus, the quadratus lumborum, the greatest weakness is in with fatty degeneration, the multifidus muscle. Now that's not me. That's literature, and I can, if you want, I can give you all the references. Just rest assured, you must strengthen multifidus muscles, and that's going to take you at least a month to gain that patient's confidence, their home exercise, and the strengthening of the multifidus and the gluteus maximus. If you haven't checked those muscles on your patient, just have them lie down, invert the foot, lift the leg, palpate the gluteus, and see that they lose that gluteus on the side of radicular pain, or both sides with just plain simple spinal stenosis. So number 1, you're not treating long enough. You're not, in my opinion, training the patient in their exercise program. And if you're expecting that within 1 to 2 weeks that they achieve maximum improvement, in my opinion, that's an unrealistic expectation. I tell people that we treat that it'll take you 2 to 3 months for me to attain the maximum improvement that I can give you. And even then, sometimes it's longer. And again, I explain to them that relief may be 30, 40%. How would you feel about that? And if they expect, and I've had it happen to me, they said, well, I'll try surgery. Oh, really? Did you ask your surgeon what a realistic expectation is of surgery? In a study, 50% of people get some relief from surgery, 50% of the same or worse. I don't know that I answered that question.
Yeah, I think it's just, you're hoping, I think she was hoping for a longer term of relief rather than just a week and then the patient has to be treated again in a week. I think as we get older, I mean, I'm even there, you know, you got to be treated more often. Spinal stenosis is with you forever and you got to contain it. And I wrote a brochure on spinal stenosis, and it talks a little about how to
have your patient read this.
Yeah, it doesn't go away, and it won't stay away forever, especially when you do certain things.
Right. Your patient will never be well. Yeah. We have a saying, we don't cure back pain, we control back pain. I would brace your patient. Yeah, put the belt on them. I said before that we brace three things: disc herniation, spondylolisthesis, and Bertolotti syndrome. Brace your case. Teach them to avoid the movements that aggravate them. Because if your people are like mine, they cheat. Heck, I cheat with my own back, and I pay a price for it with pain. But give them this. It explains how we treat, what's a realistic expectation, and in that time, you know what? If your patient gets relief for 1 to 2 weeks, according to the recent research out of Europe by people like LeBouf and Harbison, once you determine what gives the patients relief, you continue to treat them. Now, it used to be that we felt that supportive care was frowned upon. Not anymore. The new papers show, even Patricia Herman from RAND, along with people like Eric Hurwitz and Ian Coulter and Christine Gertz, tell you that you must use continual treatment to maintain that degree of relief. Hang in there, doctor. You're doing a good job for your patient. If there are no progressive neurological deficits demanding interdisciplinary care, educate them about realistic expectations.
You got 4 minutes, and I'm going to cut you off. I've got to thank you from Dr. McGinnis for this wonderful learning opportunity. Perfect way for lunch break. All the best. Happy belated Father's Day.
John McGinnis.
Yes.
Now, John McGinnis, as an ACA board of governor and a great family of chiropractic doctors, if he says this was worthwhile, I feel enthused. Thanks, John.
I have one more case.
Yep.
All right. Prosthetic disc, L4-5, continued pain. How would you treat them?
I've done them. Let's talk about disc prostheses. In my city, they were done maybe 6 to 8 years ago. We had a good local surgeon, one who's spoken at our conferences. When you come here, you've heard Dr. Shugart speak. Excellent orthopedic surgeon. He was putting in the Charité discs and Maverick discs for the lumbar spine. And I've had the occasion of treating them. One of them was they put an L4 disc, which I thought was a little odd in a 20-year-old. You know, they usually put artificial discs in younger people, not older people with stenosis. And this lady, this young girl, who incidentally goes to our church, and I know the whole family.
HIPAA.
Yeah, I can't. We treated her. It turned out that she had an L5 disc herniation. So I treated the L5 disc herniation with protocol 1, totally manual, as gentle, no more than 2-3 pounds of distractive force. She slowly healed. The whole family was happy. Now, you may have adjacent segment disease. It might have been at 3-4. In this case, it was at 5-1. So the question is, how do I treat them?
Yep.
You treat the adjacent segment, where the movement's going to move from there someplace. And can I make this comment to you? Have you read our post-surgical continued pain patient papers? I presented this case in Singapore in 2016 at, what was the conference?
Pelvic pain and World Congress.
Yeah, Andre Vleeming was in charge of it.
Yep.
And Dr. Gudavale, we were both there. We presented the paper. It was on 69 cases of post-surgical continued pain. No longer is it called failed back surgical syndrome because the surgeon said that's not a complimentary thing. Well, we didn't name it. They named it that. Now they call it post-surgical continued pain. The surgery worked. They just didn't get relief. And so we did 69 cases. You remember the outcome of that paper? 70% of the people got 50% relief. To me, that was miraculous. That was 15 chiropractors, Cox certified doctors who treated over a 6-month period all patients who came to them as failed back surgical syndromes or post-surgery continued pain patients. And doctor, you give them 50% relief. That's pretty darn good. Surgeons wish they could have gotten that. And it is by the interdisciplinary care that we will grow as a profession. I certainly hope that you recognize that we are treating by far the majority of these people. It is up to us to do the research, train the best back spine specialists in our country and throughout the world. We have doctors all over the world doing this technique now, and then get patients preference for it. And as we grow and gain more of these people, we will all be very busy. I'd like to end this with one statistic for you. The physical therapists have done a study, and I'd like to ask you a question of what they found. I have the 2 papers for you. What % of people going to a general practitioner for musculoskeletal disease are referred to a physical therapist? 10%. It's even less than that for chiropractors. The great news is, imagine what would happen and will happen when that percentage doubles. Thank you for studying with me. This has been a pretty exciting seminar.
Yeah, we did well. We're not sure when our next date is. Keep up free videos, YouTube and Facebook. I post stuff there all the time. I've been posting a lot of links through the chat box today too, so you can check on those. If you want to study more on some different guidelines for Cox Technique and choosing wisely, or 160 of the other things we have, courses we have there, go to our learning management system online for CE. We have workshops, online CE, and seminars. Our next one is here in Fort Wayne, Part 3 cervical. We're going to keep doing them in Indiana. I can't seem to get enough people on the coast just yet, but we'll get through this COVID thing one way or another. So come to Fort Wayne. We are having a great time here. Cox Table by Haven Medical. Without them, we certainly wouldn't be able to do what we are doing. And Amanda's there to ask and answer any questions. These are all of our links. Anything Cox Technique related, go to coxtechnique.com. Everything goes off of there. This has been fun and wild. I'm going to, next time I think I'll take control and I can kind of bring up pages as you're talking about control not here, and instead of just sending links out. So this was fun. If you like doing this, let us know and we'll do it next time as well. Hope you have a great afternoon with your patients. It's always fun.
My last comment is, I feel just a slight anal sphincter in opening up to you people this way. And I think you understand, but I enjoyed it very much.
I think we did all right. So have a great afternoon. We'll see you next time around.